in the professional literature is that he also is a superb writer and has written, what is it now, 7 books? 7 books that cross over in many cases between the professional communities that are interested in the topic and a wider public audience. And I think that Bob is about to do this again with his newest book, which is in the area of genetics and is the background for the talk that we're going to hear from him today. I'm going to hold up this book, which is this flyer, which should be at your table. It is forthcoming in February, and it's called Am I My Genes? Confronting Hate and Family Secrets in the Age of Genetic Testing. I haven't read it yet, but based on what I know from his other works, I expect that it's going to be both informative, provocative, and also a very good read. In line with that, we've asked Bob if he would come and give us a preview of his thinking that is in that book, and with that, would you join me in welcoming Dr. Klitzman to conference.
Well, thank you, Ruth, for that very generous and warm introduction, and it's great to be here. I'm honored and delighted, and it's great to see some friends in the audience, fellow travelers in the world of bioethics, and new faces as well. And just possibly a little more light here.
Yeah.
I'm not going to use PowerPoint, so I'd like my...
There's the light that goes right to the light.
There you go, right, okay. So as Ruth mentioned, I'm going to be talking about research that I've been conducting that has led to a book that I'm coming out, Am I My Genes? And this is work that was conducted with sponsorship from the Ethical, Legal, and Social Implications branch of the National Human Genome Research Institute. And just as background, obviously the amount of genetics research in this country and in the world is booming. The amount of genetic testing that is becoming available and that is being conducted is also rapidly increasing. We've gone from studying just single nucleotide polymorphisms to, of course, sequencing entire genomes. The prices of that are coming down rapidly. There's biobanking going on at every major medical center in the United States and elsewhere. There's also direct consumer advertising and marketing about genetic tests. And so the terrain is rapidly changing. There is a lot of promise of genetics, but there are fears that there's a lot of hype as well. And there have been some quantitative studies to see how patients themselves are understanding this. But many, many questions remain about how really people who are at risk of genetic diseases and others, and that includes all of us, how we understand what's going on, how we understand the fact that there is genetic testing that is increasingly becoming available that can tell us something about ourselves that may or may not be meaningful in various ways. And so when I looked at the quantitative studies, most of them followed rational choice models, and I realized that there's a need really to understand these issues qualitatively, to understand how people understand these issues, what their views, their myths, their superstitions, their beliefs are. And that's what I set out to do, and I'm going to highlight a few of these issues today. And as background, what I did was interview 65 people who were at risk of 3 diseases, either Huntington's disease, breast cancer, or alpha-1 antitrypsin deficiency, which is a somewhat rare enzyme deficiency that leads to liver and lung problems for which there's a definitive test. And these 3 diseases obviously differ in several ways. Huntington's is an autosomal dominant disorder. There's no treatment. BRCA and BRCA1 and 2, as many of you know in this audience, are genetic mutations associated with breast cancer. About 5 or 10% of all breast cancer involves one of these mutations. If you have the mutation, there's about a 50% chance you'll get the disease, more or less. In alpha-1, both homozygotes and heterozygotes get symptoms. Homozygotes get it more severely if they have the mutation from both parents. But there is treatment. There is enzyme replacement called prolastin, but it costs $19,000 a year. And in fact, the only case of genetic discrimination that the EEOC has ruled on involved the case of alpha, where a woman was doing very well at work. She was diagnosed with alpha, had to start prolastin. The cost, $19,000 a year, made her company's insurance premiums go up, and she was fired. She went to the EEOC, which ruled in her favor. And people are also eligible for organ transplants if they have alphas, I'll talk about. And what I found is that though there were some differences, obviously, between these diseases, there were similar underlying questions and tensions, ethical debates, policy issues that arose, and I'm going to focus on those today. Basically, across the board, what I found is that people really wrestled to make sense of this information. So as I started doing interviews, people would tell me things like the following. A woman with BRCA who had the mutation, had breast cancer, would say, you know, I always knew I shouldn't have stayed in that crappy relationship all those years. And I'd say, why is that? And she'd say, well, that's why I have breast cancer. And I'd say, well, you have the mutation. And she'd say, oh, yeah, but what triggered it was that crappy relationship and the stress, and I always told myself that I should have stayed in that relationship. Or someone else would say, well, you know, I always knew I should have stayed in that awful job. Well, why is that? Well, that's why I have breast cancer. But you have the mutation. Oh, yeah, but it's the stress of that awful job is what triggered it. Similarly, or not so similarly, I interviewed a group of African-American women from the Bronx, and they would say, you know, it's all that crap that they dump up in the water in the Bronx that they would never dump in Manhattan. That's why I have breast cancer. And that, what I quickly realized is people construct meanings and interpret genetic information in very different ways than we as providers might think. That people have narratives of their lives, they have stories of their lives, and they get this bit of information, which we see as very objective, yes, no, you have it, you don't, you check the box. And they see it in very different ways that have all kinds of meanings to them based on how they view their lives, view political issues, etc. And people really underwent a journey as they began to incorporate this information in their lives. And I've, in the book and in my mind, I've really seen sort of four areas in which this occurs. There's genes playing themselves out in the family, in people's minds, in the clinic, and then more broadly in society. And within families, two major issues are whether to test and whether to disclose. And these turn out to be very closely linked. So many people, in thinking whether to test, really learned of their risk years before they decided whether to actually test or not, because someone in their family often said, we have this mutation in our family. And people were aware, particularly with Huntington's, that this is in the family. And people then struggle for several years often before they even go to a genetic counselor's office about whether they should take that step. And a number of issues arose. So long-lost relatives suddenly played an important role in people's lives. So people would say, you know, I got this email from this long-lost relative. My father's family moved to Texas years ago. I haven't heard of any of these people or heard from them in 20 years. Suddenly I get an email saying, you know, we have this mutation in our family, alpha, Huntington's, whatever, you should get tested. Similarly, though, people I interviewed then said, you know, I tested, the doctor told me to test whatever, and then I wondered, well, should I contact these long-lost relatives who I haven't seen in 20 years? I'm not close to them. But suddenly, the biological link trumps whatever social link they may have. So a number of people felt that because they're biologically linked, they now have a moral responsibility to reach out to these people whom they otherwise would have no contact with, because socially they don't feel any connection. They barely know each other. Sometimes they say, well, I know there's a first name because whatever, and so I Googled the person and said, you know, was this you? Was your grandfather so-and-so? And so there's partly through the internet all kinds of links going on. Obviously people often tested because they felt perhaps they could do something about it, where that was the case. And people also said, you know, well, I'm told, you know, you should test if you're the type that does better knowing. And so I wondered, am I the type that does better knowing? And this was a phrase, and particularly in the HD, the Huntington's community, this is sort of a phrase that's out there. And when you begin to push it, it's not really clear what that means, right? What is the type that does better knowing, right? So in some cases, there were healthcare providers who felt comfortable with this kind of complex statistical medical information. But others wrestled to figure out, are they that type or not? And people would say, you know, I went to the genetic counselor for 6 months. I thought I was that type, and I realized in the end I wasn't that type. But I think it's a question that we need to think about in terms of research as we go forward about what that means. I'll come back to that. Others tested because they wanted to help others, but within families this was often complex. So women would say, you know, I decided to get tested, so I can really tell my daughters, we have this mutation in the family, you have to monitor yourself, you have to take care of yourself. And yet often the daughters would say, you know, Mom, I don't want to know the result because if I'm asked for insurance, I don't want to say I know anything. I'm don't want to deal with this. You had breast cancer. That's your story. I'm young. I want to lead my own life. I don't want to have to think about these things. And conversely, there would be pressure in families. So sometimes someone who had breast cancer would be told, you have breast cancer. Your insurance could cover testing. There'll be no discrimination. I've not had breast cancer. I want you to test so we find out if we have a mutation in our family, so I then know, do I have to worry? And we may then say, well, I don't want to test. And there would be pressure in the family to go ahead and test nonetheless. And of course, there's all kinds of complex dynamics when you're talking about family systems. Of course, providers don't always offer the test, particularly for alpha, which is a rare disease. A number of patients said they would go to several different doctors over the years. They would have symptoms of COPD that resembled emphysema. Docs would say, well, you must have been a smoker. They'd say I was not a smoker. They would not get better. And finally, they'd eventually find their way to a doctor who would test for alpha. But one realizes the difficult journeys that patients with a rare disease may have to find someone who thinks, genetic test. Of course, the concern is that physicians may either over-test or, in this case, under-test for conditions for which there are genetic markers. And people decide not to test because of fears of discrimination, and we're quite wary of laws that protect them. I'll get back to that. And for breast cancer, even people often did not test because they did not want to then have to deal with the question of prophylactic surgery. So if people have a BRCA mutation, they have the option of having prophylactic mastectomies and oophorectomies. And whereas physicians often think of the order of events being first you test and then you think of these surgeries as prophylactic measures, a number of patients think, well, I don't want the prophylactic measures, so I won't test. Genetic counselor experiences vary from a lot to a little. Sometimes physicians will just write a prescription, go get a Huntington's disease test. Other times people felt, I knew I wanted the test, went on for months, the genetic counseling, I didn't feel that was necessary. After testing, of course, there are issues of disclosure, and it became apparent that there are a number of different ethical and psychological issues that emerged. So there were people who dealt with questions of whether they should tell, whom they should tell, what to tell, when to tell, how to tell. So clearly, adults in your immediate family, people tend to tell. But people struggled with what about, as I mentioned, long-lost relatives, but also estranged members of my family or one's family. So I haven't talked to my sister in 20 years. She's on the adjective. And why should I tell her? Why should I do this thing? Do I have responsibility to her, even though she's been mean to me, et cetera, et cetera? And there were often tensions, obviously. And as I mentioned, a number of people said, I know you're testing. I don't want, please do not tell me the results, because then I will have to disclose if I'm applying for life insurance, disability insurance, long-term care insurance, in addition to health insurance. There are questions of when to tell, and people struggled. Well, should I wait until I find out that the test result is negative and then tell? Or should I say, I'm going to go next week to get genetic counseling and then get the genetic test? At what point do you say? And a number of people wrestled with, they don't want to keep their family too anxious. After all, the result may be negative, but then should I wait? But then people will feel betrayed. Why didn't you tell me earlier that you were doing this? I wouldn't have wanted you to do it, or whatever. So these are complex issues, and people often found they really had to wrestle with these on their own. There were issues of how to tell. So particularly with young adults, people would say, I don't know if I should tell my 17-year-old daughter, my 20-year-old son that we have this mutation. I didn't know what to do, and slowly the information leaks out. Right? So I'm sure he or she heard me on the phone at one point, and people really struggle, and often the disclosure is not done as well as it might be. And so there aren't really clear rules and norms, and again, providers don't really deal with this as an issue. So with patients of how should you think about disclosing within your family, and obviously it's important because those who get disclosed to may then realize that they need to test. There are also questions of how much to test family members. So people would say how much to push. So, I tested. I really think my brother, sister, whomever should test. I keep telling them to test. I keep bugging them. They don't want to do it. We get in arguments about it. Or conversely, with Huntington, people would say, well, we really don't want Billy over there to test because he's not that stable. We're afraid he really can't deal with it. We don't want to really bring it up. We're afraid it can really push him over the edge. Of course, Billy may have psychiatric symptoms that are early symptoms of Huntington's. So genes obviously work in the family in different ways, but also in the mind. So people really struggled with why me? Why did I get this? And why do I have this predicament? And people would say, well, because of a mutation, but why do I have this mutation? What is, why did the roll of the dice lead to this? When as soon as people begin to sense that this was somehow my illness, my symptoms were predetermined, immediately people begin to think, well, what predetermined it? What determined it? Who predetermined it? There must be something. And people have trouble dealing with sort of this random events. What I found is people really had a sense of needing to control something. They wanted to avoid a sense of fatalism or despair, that this is something just happened, there's nothing I can do about it. Why me? Why not my sister? Or why my sister? Why not me? People had really a need to assign blame to something that made sense to them and to avoid blaming themselves. And so metaphysical issues arose. People would say, there has to be a purpose. God wouldn't just give this to me if there wasn't a reason for it. And so we have sort of this kind of thinking, superstitious thinking. And we may say, oh, we're strict scientists, we're objective, but when you think about it, we all make a wish when we blow out the birthday candles, right? I mean, sort of people have all kinds of beliefs in their mind that come to the fore when faced with these issues of faith. It's almost where it's sort of hardwired to begin to sort of look for causal explanations and make sense of things. And so, of course, there's, in terms of cause, there's physical causes, and there's obviously genetics and other biological causes. But there's also political beliefs and issues about the environment, right? Is it something in the environment? Is it genes? What's the combination? And people really wrestle to make sense of this, in part thinking, what can I control? What can I blame? What can I do about it? But people had difficulty with this. They would often look for combinations, and obviously some of this reflects issues, the underlying issues of free will versus determinism, right? How much role do we have in our lives? How much is determined for us? And people look for what I call wiggle room. Even people at risk of Huntington's would say, well, I know I have the Huntington's mutation, so I'm going to get this, but when I get it is up to me. Or how severely I get it is up to me. Or I have alpha, yes, that's determined, but how severely I get it, or whether or not I can avoid environmental exacerbants, that's up to me. And people really look to sort of parse what they could control versus what they couldn't control, but that was often difficult, and the reality may not map onto what they felt. People also developed what I saw as sort of personal epidemiology. So people would try to figure out, well, why did I get the mutation but not my sisters, or why did I get the disease but not these people, or why did they get it, not me? And people would say, well, one Asian woman I interviewed, for instance, had a BRCA and the mutation. She said, well, it must all be because I'm more assimilated here in this country than my relatives, and that's why I got sick. And even though she had the mutation, she said, well, that somehow must have played a role. They must have the mutation also, but didn't express itself. Or people would say, my family's from near New Orleans, and everyone's dumping all that stuff in the water, and everyone has cancer now. And so it must be the environment, even though they may or may not have the mutation. So people really wrestle to make sense not only of their own illness and its course, but of those in their family, because they have all these data points, right? If you have a mutation, that means there are other people who have it, and who has it, doesn't have it, etc. And again, the sort of people would talk about, well, there must be this sort of cosmic roll of the dice. But that gets very hard. And again, this sort of language of sort of this being something cosmic and metaphysical kept emerging. And made me think even Einstein at one point, right, famously said that God does not roll dice. And so the notion that your fate is somehow being determined by this roll of the dice was quite difficult for people to conceptualize on a personal daily level. And people also look for metaphors. So people would say, well, there must have been a trigger, or the mutation gives me a head start, or it's sort of a ticking time bomb and something made it go off. And again, people look for things from their everyday life to make sense of this. As I said, there's also issues of blame, particularly for people with alpha. Having the mutation really got them off the hook. So people would say, people felt, well, it must be because I smoked that I have these symptoms, and now that I have the mutation, what a relief. It's great news. It means that I get treatment, I feel better as a result, and it's not my fault. On the other hand, those who did smoke or hung out in smoky places had more trouble figuring, well, is it somehow still my fault in some way, and how do I tease that apart? And People with Huntington's obviously had parents with Huntington's who were often not great parents because they had psychiatric symptoms. And so a few people had had abuse when they were growing up. And they'd say, well, I don't know how much to blame my father for the abuse that I got when I was growing up. Was that the Huntington's? Was that him? Now that I know it's Huntington's and it's a mutation, which I didn't understand as a kid, and now I understand more about the mutation, how it works, how much do I blame him? How much do I forgive him? I don't know what to do. The other issue that comes up is luck. So people would constantly say, well, it's just lucky that I didn't get it. Or, I had bad luck. I got the mutation. And when I began to probe about luck, it was quite interesting because luck comes up a lot in medicine, actually. And if you look up in Medline luck, hundreds of articles come up. It's often in the title. None of them define luck. I looked at 200 articles, not a single one defined luck. And what's interesting is luck has been looked at from a number of disciplines. So philosophers, there's a literature, have talked about luck. And luck basically removes you from moral responsibility, philosophers say. There's been a literature, Thomas Nagel and others have written about this, that if I'm lucky, it's not my fault. If I'm unlucky, it means it's not my fault. Psychologists, on the other hand, have looked at luck as a matter of control. Right? If something is just a matter of luck, I don't control it. Right? Or if I don't control it, it's a matter of luck. Anthropologists have looked at luck as being akin to sort of magic, right? So if, Evans Pritchard wrote about concepts of luck and magic in primitive societies as sort of explanatory systems. Here, really, all three of those themes come up in how people think about genetics in their lives, as being a matter of blame, cause. The cause isn't clear, as is the case increasingly with many genetics. Diseases for which there are some genetic markers that are associated. People want control, et cetera. There's also differences in toleration of ambiguity. And John Keats, the poet, famously said that came up with the concept of negative capability. That he argued that what's important in poetry and other things is whether people can contain in their minds two competing notions at the same time and not have to settle on one. Be able to have these competing notions. And people had difficulty and differences in how well they were able to do that. Some people said, I need to draw a line. I know it could be both the environment and genetics, but it's really the environment. Or it could be the environment and genetics and behavior, but it's really whatever it is. People had difficulty or ended up sort of wanting to sort of blame something or make sense of this in some way. These concepts, of course, had a lot of implications. If one feels less blameworthy, the disease could be less stigmatized. Some of these patients were therefore more likely to go and get testing, more likely to disclose to other people because it wasn't that big a deal, as opposed to those who felt more blameworthy, etc. And similarly, if you're seeking control, if you have a sense of control, that can lower stress as well. And again, though, I think this is a level of thinking that a lot of clinicians don't think about in terms of what their patients are undergoing, that in fact can affect decisions that patients make about testing and disclosure. There are also questions about identity. Am I my genes? A few people said to me in various ways. And it was quite difficult to conceptualize this as well. So we know that disease, and there's a lot been written about chronic disease as altering one's identity. But with a lot of conditions, it gets quite different. So you could be perfectly healthy, have no symptoms, but have this mutation. You could really struggle with what does that mean? Am I sick? Well, I'm not really sick. Am I diseased? I'm not really diseased. Am I unhealthy? Not really. Am I predisposed? Yes, but what does that mean to be predisposed? Sort of being two places and not either one. I'm sort of in between. People would qualify. They'd say, well, I'm a healthy alpha. I have the mutation, but I'm healthy. Or I'm healthy but doomed. Or healthy but cursed. I have this curse over me. And people really try to put these things together in their minds in different ways, using metaphors. There was a question, is this a big part of me, a little part of me? Am I a mutant? And a number of people who had had prior trauma in their lives tended to say, I must be flawed. This proves that I'm flawed. People who had major depression or people who'd been abused often said, I always knew there was something wrong with me. And now I'm told I have this mutation. I always knew there was something wrong with me. I see I'm a freak of nature. And again, people have these sort of these pre-existing narratives of their lives or stories of their lives and sort of, again, graft this onto that. It's almost genetic test as Rorschach, where people sort of look into it and walk away with different interpretations based on where they've been. And again, these decisions too affect, these views of self affect decisions about testing, disclosure, reproductive decisions that we'll talk about in a moment, etc. Another area were misunderstandings, and there were three areas of misunderstandings people had. One was about Mendelian genetics, one was about genetic tests, one was about statistics. So about Mendelian genetics, people would say, well, I always knew I'm more like my father, or I'm more like my mother, right? And so if my mother had the Huntington's mutation and I look more like my mother, then of course I'm going to have the Huntington's mutation. So I don't need to get tested or whatever. And people would say, well, I just assume I got more genetic material from my father. I mean, look, I'm more like my father. So there are these kinds of mistaken notions about genetics, sort of folk wisdom about genetics, if you will. There's also notions that genes sort together, for instance. And about genetic tests, there were also misunderstandings. So there was often a sense of over-predictiveness. So people would say, well, of course, if I have the mutation, I'll get the disease, and not really understanding the complexities. And there were also misunderstandings about statistics, particularly that each toss of the coin is independent, so to speak. So people would say, my sister tested negative for the Huntington's mutation. I was devastated. So, of course, if she doesn't have it, and it's 50-50, then I, of course, have it. Or my sister found out she had the mutation, and I was just thrilled. I was so happy, because that means I don't need to get tested. She got it, I did. Etc. There were also, interestingly, mistakes about the odds of responses. So people would say, well, I thought about the breast cancer test, and it's, of course, 50-50 I have the mutation or not, right? Because it's either positive or negative, so it's 50-50. Well, of course, even if you have breast cancer, the chance that it's a genetic kind is only 5 or 10%, right? So, in fact, the odds that you have are going to have the mutation are not 50-50, but, in fact, whatever, 90%, 10%. But again, these kinds of misunderstandings frequently arose and then shaped what people decided in terms of whether to test, whether to tell, etc. And interestingly, there were also misunderstandings not only among the, quote, index patient, but those in his or her life. So people would say, my husband says, don't you dare get testing because it's meaningless, or you have to get tested because whatever. And so people would be pressured in various ways from people in their family who had misunderstandings. Or a few women said, my significant other said, what do you need to have this prophylactic surgery for? You had cancer, they got rid of it. And, quote, my husband didn't understand that this is a mutation, et cetera, et cetera. Right, and so people were not just risk averse, but I think also risk averse, who wanted a sense of hope and avoid fatalism and despair and all this. And were often quite distressed because of their misunderstandings. As I mentioned, a third area were the way genes played out in the clinic. What should I do about my genes? Or what should others in my family do about these genes? And obviously these symptoms that these mutations could cause all were stressful in and of themselves. And the treatment decisions were quite difficult. So for alpha, for instance, prolastin, as I said, is available. But for many years, until very recently, there was a shortage. And so the alpha community, their patient organizations, decided that work with the pharmaceutical companies that were making it to distribute and ration the amount of prolastin. And they would decide, okay, what we'll do is we'll all agree that we'll all get 10 months of the treatment that will each spread out over 12 months. And this became quite controversial, as you can imagine, because some people said, well, these organizations are just lackeys of the pharmaceutical companies. Others felt they were doing a wonderful thing. People had to decide whether to support this or not, whether to join this group effort. It raised a lot of issues. Generally, they did join, but it was a source of difficulty. And also, as I mentioned, people who have alpha or are at risk of it are eligible for organ transplantation of liver or lungs. And people would game the system. People would say, well, we have alpha, so we know we're going to get the symptoms, so we can put ourselves on the transplant list now, right? Because we may have 5-10 years before we actually get sick. So, we tell everyone with alpha to do this. And of course, that then creates problems. Is that right to do, et cetera? Questions about indebtedness to donors, of course, with organ transplantation, which Renee Fox and others have written about in other contexts. And there are also difficulties because even if one gets a organ transplant with alpha, the disease will come back, right? It's not just the diseased organ, but it's a genetic disease. And people had difficulty with that often, that, okay, I have healthy organs, but I'm still sick, or I'm still going to get sick, or I know my organs are going to be getting sick inside my body, and there's nothing I can do about it. With BRCA2, obviously, there are questions about prophylactic surgery, as I mentioned, and there were risks both of having the surgery, people felt, and it changes one's self-image, one's body, one's image of one's body, others' images of one's body, one often thought, and there were, of course, risks of not having surgery. So there are risks on both sides that were often difficult. And people really wondered which surgery they should have and when. Should they have bilateral mastectomies? Should they have oophorectomies? Could they wait? If so, how long? And it became clear that it was very difficult to talk to one's physician about this. People felt that either physicians were too cavalier or were not directive enough. So people would say, on the one hand, my physician just said, we'll just take out your ovaries and breasts, and I was just horrified. Other times, people would say, I really want my physician to tell me what to do, and he said, this is so sensitive and so complex, and there are obviously issues of sexuality, these are taboo topics, that, my doctor just would not tell me what to do. It was so frustrating because I wanted an answer. I wanted him to tell me or her to tell me, and I couldn't get an answer. And again, I think we really need to train physicians going forward to deal with these kinds of complex issues. Some people wanting unambiguous answers, others not. Reproductive decisions were another area that came up in terms of what to do. And I actually went into this thinking I would hear a lot about issues of disclosure and testing. I'd done previous work on HIV testing and disclosure, and it was sort of a model I used in going into this work. And I was surprised that people would tell me, I don't really care about that or about discrimination, whatever. I'm worried about, should I adopt? Should I abort? Should I have kids? Should I not have kids? Should I screen embryos? Should I not get married? What should I do? Particularly for younger people, these were major issues that they were dealing with. And when I checked the literature, there's been a little work done on this, and people felt that reproductive decisions in these contexts often involve responsibility to others. When you interview people, it became clear that there were different others to whom one had responsibility to. These responsibilities could in fact conflict. So people would say, there's what I want to do, there's what my husband wants to do, or my wife. Then I have responsibilities to my current children. What about to these future children? What about to society at large? Should I be screening embryos for my disease? What about religious views? God would only give me what I can handle, so is this going against God if I'm somehow going to screen embryos or do amniocentesis and abort a fetus because of having Huntington's disease? And people really struggled with this. Some decided, particularly from Huntington's, to have children before they tested. Because I don't know whether I have the mutation or not, we'll have kids now. And often spouses conflicted on this, right, and disagreed on this. And then healthcare workers were often quite appalled by this when they found out that these people had gone and had a child before testing, when that's not responsible. There was amniocentesis, followed by abortion potentially, and people wrestled with this. Even those who were not interested in having kids, others in their family were going through this. They would say, my sister's really struggling what to do, or my brother, or whatever. And there were questions that people would spontaneously bring up. For which diseases would it be okay to abort? People were often pro-choice, but anti-eugenics, and realized the sort of eugenic possibilities here, and really struggled with that. And also, what does it mean that I would abort a child that has my disease? Right? That I would have aborted myself. I would have been aborted. What am I saying about myself? What am I, here I lived all these good years. Is that the right thing to do, to abort someone a future child of mine who would have what I have? And people, again, had difficulty knowing what to do. And physicians were very unhelpful on this, or really had very little to say about it often, partly because these are difficult moral issues, obviously. Some people said, I would want to have an amnio, but I wouldn't abort. I would just want to know, to prepare me. Of course, physicians would say in that case, you shouldn't have an amnio if you're not going to abort the fetus as a result. There's also screening embryos, pre-implantation genetic diagnosis that many of you may know about, in which if one's undergoing IVF, when the blastocyst, when the embryo is at an 8-cell stage, we can take one cell out and diagnose it for about 5,000 different conditions at this point, and people are doing this for gender as well as other things. Obviously raises a lot of moral issues. At Columbia, we are doing this for Huntington's at the moment, and we have non-disclosing PGD, where someone at risk of Huntington's can see, are any of the embryos, do any of them have the Huntington's mutation, and just those won't be implanted, but I won't be told if any of them were found to have Huntington's mutation. So I won't know if I actually am at risk if I don't want to know, but I'll make sure my kids are okay. Interestingly, in those cases, 75% of the couples do have the mutation. In other words, they probably generally know they have Huntington's. And the providers are often a little uncomfortable because what does this mean in terms of parenting skills? The parents are going to get sick. Clinicians in a number of places are uncomfortable. Should we be the gatekeepers saying, really, we don't know how good a parent you're going to be. You shouldn't be doing this. Is that the role of providers? Obviously, a whole set of moral issues we can talk about. There are issues of cost. Interestingly, insurance companies won't pay for PGD. By and large, they feel that, okay, even if it's Huntington's, and PGD's been used for breast cancer as well, I should say, insurance companies feel, well, by the time that that individual is born and grows up and has symptoms, the odds that we're going to be the insurer are very slim. So even though, in the long run, it may be cost effective, for us it's not. Why should we pay a few $1,000s for PGD, which isn't cheap? And as I said, there are obviously input from others can conflict here, from people in your family. Some decide not to have children with HD. Some decided to abstain from marriage or relationships. Or a number of people, young guys with HD, would say, I just decided, it's easier to date someone who has already had kids or doesn't want kids, because then we just don't go there. There were issues with privacy and insurance, obviously. People felt there's only privacy if you make it. There's a lot of wariness of laws meant to protect privacy, particularly with electronic medical records. A number of people felt stuck in jobs or locations because of insurance. So some would say, I have this job now, I can't stand my job, but I get my insurance there. And my insurance covers my doc who knows about this disease. I'm afraid that if I switch jobs, different insurance plan, I don't know if they're going to cover that doc. I don't want to chance it. A few people said, I have alpha. I'd love to move south, which would be better for my condition. But, technically, I know my insurance is supposed to come with me. It won't change. I just don't trust it. Everything's taken care of now. Better not rock the boat. Of course, the question of whether to use insurance for testing. Many people decided not to if they can afford it. Not all can afford to have testing by paying out of pocket. And whether to tell insurers and whether to tell doctors. So a number of people said, I just decided I'm not going to tell my doctors that I have Huntington's in the family or that I'm at risk. And Huntington's groups are telling patients at this point, tell your doctor, quote, that there's something I want to tell you, but I don't want you to put it in the chart. Is that okay? Of course, if a physician's told us, what is a physician to do, right? We don't know the information. We can't say we're going to put it in the chart or not, right? It might be relevant down the line if the patient shows up in the ER at some point. Do we want people to keep shadow charts, keep the information separately? Some people said their doctors were doing that. It's not clear how that works with electronic medical records, if people put things in codes. Again, a lot of gray areas that people were quite wary about. A few people said they've tried to clean up their records. One woman said, I realized that when I had my child, I mentioned Huntington's. I don't want that in my records. So I went to the clinic. They wouldn't take it out of the record. One woman went to a clinic that gave her records, just ripped out the pages that had Huntington's on it. People said they contacted privacy officers in hospitals who really couldn't help them in the end. And it's a question. What if you give information, you want to take it back? Well, of course, realistically, you can't. And that was quite difficult. There was also subtle discrimination, which came up. So people would say, well, I wasn't promoted. I thought I should have been promoted. And I don't know, is it because they know that I have Huntington in my family, or they know that I had breast cancer? No one said it's because of that. They didn't fire me, but it should have been, I should have been the one who was promoted when my boss left. It was quite hard. And part of this was related to disclosure outside the family. So people would say, I have my work friends. Do I tell them? Do I not tell them? Or, I share a cubicle at work with someone, and I know they heard me on the phone the day I got my results, or I was really upset, I was crying, she asked what's wrong, I told her, and I thought, oh my God, is the whole office going to find out now? Like, how worried should I be? Or my boss would know, and bosses would say, I don't stop right there, I don't want to know anything more. I don't want to officially know. What does it mean for a boss to sort of officially know versus unofficially know medical information about oneself or genetic information, right? But in the realities of sort of lived experience, these are issues. We sort of know things but don't officially know them, right? And people are quite concerned. Some people said, at work I don't check any websites of my disease because I'm afraid it'll pop up. Or some people say, I check Huntington's or I check out, but I check a lot of other diseases, just so they can't trace it just to that one disease. Or, I'm on a listserv, but I set up a separate Gmail account because I don't want anything coming, Huntington's disease support group next Tuesday on the subject line, right? So, again, these are, in the real world, these are difficult issues. And people often did not think about these in advance. No one said think about these issues in advance, right? And suddenly you find yourself having told your work friends and then not knowing who knows, can there be subtle discrimination, et cetera. So, of course, we have GINA, the Genetic Information Non-Discrimination Act. But if you think about any other kind of discrimination, think of civil rights legislation, right? One piece of legislation did not get rid of racial discrimination in this country or any other kind of discrimination, right? It's a long process of different laws, people gaming around it, court legislation, etc. There were also genetic communities. So a number of people, particularly for rare diseases, as some of these were suddenly thrilled that there was a genetic community out there for rare disease. Internet's great, but a number of questions came up. These groups can offer treatment, support, research, but people wondered how involved to be. Should I volunteer? Should I get involved in research studies? Should I get involved in political action? Because all these groups are politically active as well and want you to go talk to representatives in Washington. Do I want to do that? Should I be anonymous or not online? People would say, well, I was on an online support group, and they all said they're going to get together in this restaurant in my town for dinner on whatever night. Should I go? And some people would go, and they'd make up, on the name tag, you put your real name, you put your screen name, Susie's mom on your name tag, what do you do? And again, these were difficult issues. People in support groups would often be helped, but then begin to see sicker patients, and then feel they don't want to be that involved. Then wonder, well, do I have an obligation to be involved? They were so helpful to me. What do I do now? Obviously, differences in these relationships over time. People often were in support groups or online or on the phone, and then it kind of morphs. After a while, we both got over our illness. Do we stay friends? Are we friends? Are we sort of friends? And people have different ways of describing sort of disease group friends, that they sort of have this in common, and sometimes it bridges over other things. Sometimes there are boundaries that have to be negotiated. A number of issues of political issues. Should there be more screening? If so, for whom? A number of them talked about testing samples in the future. And most of these people thought that research was great. Interestingly, my sense was that they had no problem with their specimens being used for other research. It seemed in part because, of course, it would benefit not just them, but their family. So they realized, if this is my family, my aunts, my uncles, cousins, nephews, etc., well, if I get involved in research, it's really immediately helping not just me, but others that are not just anonymous others, but people I know. And that was often, so the notion of benefit, I think, in people's minds was different than for participation in some other kinds of diseases. Sometimes tariff issues came up, for Huntington's, if someone did not want to tell a spouse or tell a strange sister, should the doctor ever break confidentiality? People felt doctors should not, but we can talk about that. There were issues about genetic databases for law enforcement, et cetera, that came up and people talked about. I can go on, but I thought I would just, sort of having laid out a number of these issues to give you a sense of the terrain, and as I mentioned, there's a book coming out, you see, which goes into all these in more depth, but overall, I'd say, it became clear to me that there were a number of areas, needs of better professional education and public education, that clearly I think physicians were really not trained or tuned or aware, as we should be, of these complex moral and psychological issues around disclosure, around reproductive issues, around misunderstandings, the ways in which our patients can understand this kind of information, how directive to be, both about genetic testing and about procedures that may be necessary. Physicians are trained to be very directive, and of course that may not be the model for genetic counseling. The problem is, as many of you in the audience know, is that there's a great shortage of genetic counselors in this country. There's something like 1,800 in total in the whole country. Most insurance companies do not reimburse for it. Physicians are then left to sort of struggle to do it on their own. They don't really know how to do it. They don't feel comfortable doing it. They're not sure how to do it. There's also, obviously, for public education, I think we really need to sort of clarify issues around the laws and increase genetic literacy. In terms of research, I think that qualitative methods, I think, are important, as I've tried to illustrate, for really teasing out a lot of these issues, and that people are not really following rational choice models. It's been the model theoretically as a framework in a lot of literature, but really draw on all kinds of myths and notions that are important to understand. It really taps into a lot of aspects of how we see ourselves. And there are a lot of ambiguities in the language. You know, what is predisposition? What is luck? What is fate? Interestingly, there's a debate going on, is there too much genetic determinism out there? What I found is that people were not genetic determinists, even though you see in the paper, there are headlines, you know, obesity gene discovered, schizophrenia gene discovered, that would suggest that we're moving towards genetic determinism. The patients I interviewed actually were quite wary of that, but for different reasons. They were looking for ways to control their environment. They were looking for things to blame. They were not just focused on the mutation is it, but for very different reasons than we might think. And I think these are important to understand. Questions about obligations and extended families. And I think also in terms of policy for insurance discrimination. Obviously, you know, gene is there. There's life insurance, disability insurance, and concerns about this, as well as for health insurance, really affect what people decide to do in terms of testing, in terms of disclosure, in terms of other health behaviors. So I think we need more attention to all this, and I think we need more genetic counselors or training other healthcare workers to plug the gap. So again, I thought I would stop there and open the floor for discussion. But I think what this suggests is the amount of work that we have. I think this is a very exciting time in terms of genetics, but for many of us, there's a lot of questions that we need to think about. So thank you.
As is our tradition, we've got 15 minutes for questions. Bob, are you okay just pointing to people?
Sure, yes.
Hi, that was very interesting work. I've been doing work looking at some of these issues in the context of families with cystic fibrosis, so childhood onset disease, and I've been having different results where people say, this is my mutation, this is what is going to happen to me. And I wonder if some of your results are because you're looking at late onset disorders, and it sounds like in some cases where people are not yet sick. And
yeah, so that's a great point. I was going to mention, I mean, I could have talked about a number of other things. I mean, I should also preface my comment on that. You know, obviously there's other tests coming down the pike also which are much less predictive, right? For autism, for Alzheimer's, there are various tests that have small bits of information. So this, I think some of the issues will be different. I think there are common things. You're right. I think these are late onset conditions, so there are other kinds of conditions, both in terms of the predictiveness of tests, in terms of when the onset is, where some of these issues will play out differently. That being said, and then of course cystic fibrosis also in terms of predictiveness, at least for some symptoms, is highly predictive, as I understand it, right? As opposed to breast cancer, where there's much more uncertainty. So obviously there's a range. My sense is, though, that certain underlying issues will pop up. So misunderstandings, I think, questions of identity, what does it mean to be a carrier even? What does it mean for reproductive issues, right? If you have cystic fibrosis, what does that mean? What should you do in terms of PGD, screening embryos, not having kids, adopting, et cetera, et cetera. So I think as we go forward, to explore how these issues are both similar and different in other conditions is very important. Yeah.
Thank you. Really, really interesting, Bob. So I'm curious about any ethical issues that you may have experienced yourself in the process. And really what I'm thinking about is sort of wearing two hats and being a qualitative interviewer and a psychiatrist.
Right.
And how you manage some of the difficult stories you may have heard during
right.
other area of expertise.
Well, I tend to debrief patients interview after at the end if I need to. So if people have really misunderstandings, for instance, I would, after the interview, I'd say, well, I'd just like to come back and talk about a few of the things we talked about, just so you know it really, and I'd correct the misunderstandings. No one was that distressed that I think they needed to go see a psychiatrist, per se. I mean, it was, although I would have if that had been the case, and when I did interviews with people with HIV, sometimes that was necessary. So I felt it was more correcting misunderstandings and at times letting them know about other resources that are out there that they might not have known about. So I think those were that's the way I dealt with it. Yes?
Given the case in which the fields moving and there are so few diseases that are so specifically genetic, and these are really with epigenetics and proteomics and metabolism, do you think that the kind of effort that would be needed to increase health literacy and maybe move towards kind of a greater genetic that are still relatively uncertain that may not pan out in the long run to be the better investment?
I think we absolutely need to increase health literacy among patients and providers. I think the fact that there is uncertainty means we need to teach people how to deal with uncertainty. And patients may not understand uncertainty. I mean, most tests that we use have much more certainty about them, right? If it's a glucose level or if it's a cholesterol level or whatever, we know much more definitively what that means. And there's so much room for misunderstanding here. Given uncertainty is very hard to deal with. So people sort of make decisions which may be right or wrong. But I think we need then to sort of embrace that and take that and make that part of the conversation. And I think maybe getting physicians to think a little bit differently, because not everything is going to be strictly evidence-based. But at least in psychiatry, we often say, we're taught often to share, look, I don't know. Patients will say, well, should I go do that? Will I make it through a PhD program if I have, manic depression or schizophrenia? We say, well, look, we don't know. But, here are ways to help you think about it. So I think, that may be more of a model or something like that. Yes?
I'm curious where you stand vis-a-vis rational actor models. So you started by saying that this is where most of the literature is. And yet you gave us lots of examples of ways in which, from within the rational actor models, one could only see people's behavior as being irrational. And I think where you ended is basically in coming back to this idea that we need to educate both physicians and patients, which would suggest to me that you would uphold those very models.
So it's a good question. I think part is because it's who's defining what is rational or not, right? So a lot of rational decision-making models take very objective factors as being the elements that are going into it, and what I find is that there's all kinds of misunderstandings, right, that are involved. But you could pretend, once you understand what someone's misunderstandings are, they may be, if you take those to be facts, people are acting rationally. If you really think that your sister has the Huntington mutation, so you don't need to get tested, even though you're beginning to act funny and people are treating you weird, right? In a way that's, quote, rational, right, from your perspective, but it's based on a false premise. So I think these are complex issues. I think the problem I see in the literature is that it ignores a lot of factors that to me are much more subjective, that are in fact driving a lot of patient behaviors. But I think there are ways potentially of trying to understand those and enter those, operationalize those. I think there's a lot of challenges. But I wouldn't say it's not worth people trying.
Yeah, I wonder if there are any sort of theoretical perspectives that you might employ that would help you analyze that material to help us understand why people actually do those things, other than that they have misunderstandings.
Right. So one of my teachers was an anthropologist, Clifford Geertz. Yeah. And Geertz emphasized a few things. One is the need for thick description, but he also would continue to make the point that we need to understand you need to understand what people are doing in a complex world from their perspectives. In other words, when he came around in anthropology in the 70s, before him there were Freudian anthropologists or Marxist anthropologists. So a Marxist anthropologist would go into any situation and they'd walk away with a conclusion, guess what, that follows Marxist principles, right, or whatever. Or Freudian would say, look, we clearly see evidence of Freud. So his point, and part of this where it's coming from, was, that's all wrong. That we need to understand how people themselves are understanding the situation that they're in. Because people do have explanatory models of their worlds, right? And we need to understand those. And so I would come back to that as a principle here, that we need to understand, how people are seeing the world in which they're in. And because that's going to be governing a lot of what they're doing, that many of us still, unfortunately, in research often still have our own theoretical views. And it's important to try to get out of those because they may not conform to what's actually happening. So I would, from a theoretical point of view, come back to that. Yes?
So in your experience talking to these patients, when you tell them that a mutation is, like, if my sister has a mutation, I don't, and that's not really how Mendelian inheritance works, how do they react to that information? Like, do they accept what you're saying, or do they still continue holding on?
they hear what I say. I'm not following up and saying that they're going to get tested as a result or not. But I say, actually, if, actually each time it's independent, they say, oh, yeah, I guess so. Or they kind of hear it. So I don't really know. I'm not doing a test afterwards to find out they walk away believing that or not. But I've at least corrected them. And again, people in the interviews, even, I know people battle between these different ways of seeing things. So even, there's one woman I interviewed said, I used to blame my breast cancer on the environment. I live on Long Island. There was all kinds of, high tension wires. I assume that's it. And then, I got tests and found out I had the mutation. And quote, I'm such a big environmentalist that I can't quite give that up. And they would struggle with this, right? So people would, take in the facts, take in their beliefs, and they're also looking, well, but then how come my sister didn't get it? Or so people were sort of looking, everyone's there, historians and philosophers of science look at how scientists, Thomas Kuhn and others, Karl Popper, look, how scientists make their decisions. So they have a paradigm and they test it versus the evidence, and then sometimes they just stick with the paradigm, and at a certain point they shift over. And I think there's really room for a psychology of science. That, right, people are sort of taking evidence or looking for evidence. What's the relevant evidence? This is what I think. Here's the new evidence. And then, at what point did people, give up the Ptolemaic system and become Copernican, right? Think that, the Earth doesn't go around, the sun doesn't go around the Earth, but vice versa. And I think that's a struggle that people depend, but that people follow the weight of evidence, by and large. On the other hand, with the metaphysical stuff, it gets a little stickier. So, I interviewed a few people who were healthcare workers, and some were religious. So I interviewed this one healthcare provider who said, I'm really not sure. Part of me thinks, yes, of course, it's mutations, but then, really kind of why do I have the mutation? There has to be a reason for this happening in the universe, et cetera, et cetera. So, but I think this is the level at which people are processing information often. Other questions? Yes.
The image of the woman who just basically takes her medical records and rips out.
Right.
That's only possible in the people.
Right.
And clearly not something that the HD support groups can advise as a practical matter.
Right.
So there's so many issues about interviews, ways, and that beg for guidance.
Right.
And I'm wondering whether, after listening to all these stories and thinking so hard about them, listening to and thinking about them, what you would now say about how people who are confronting the decision about what to share in the context where there's going to be a record should do.
Right.
Or how they should be counseled about their options, whether they should be counseled at all.
Right. I wish I had an easy answer. The answer is X. But I think it's a complex discussion that we need. I think we all need to think about. Luckily, some of the world's experts on some of these issues here. What do we do with this fact that should it be the case that once you say information to a physician, you can never get it out of the record, and it may come to haunt you and hurt you in the future? I think that at a certain point is unfair. And yet, there's a tension of, is the medical record a legal record, a medical record, both? And what does that mean, right? And if it's somehow both, right? So if it's a legal record, nothing could be changed. But then at a certain point, that gets in the way of health, I would argue. And at a certain point, it may be in patients' best interest not to have it be as rigid. A number of these, people said in response to that, some people said, well, my doctor said if anyone asked for my paper record, they would go through and they would black out everything. And I don't believe that for a minute. It's going to go to some secretary's desk, or when people would talk to their physicians, some physicians who said, no, I'm putting everything in the record, but if anyone asks, we'll just go through and black everything. And patients said, some secretary is going to know to do this and do it right and not make mistakes. I'm better off playing. I think patients decide, therefore, to play it safe. So a lot of these patients say, I've learned I keep my mouth shut. I went to a whole new healthcare system and never mentioned it. When they asked me about my old doctor, I said, it was so long ago, I don't know. I don't remember who he was.
But how is psychiatry dealing with
electronic medical records. It's a whole field that had these shadow records and had them locked separately.
Right, and also with HIV for a long time, there were shadow records where patient doctors wouldn't write in the chart. You know, I don't know. I think it's a great area for study empirically, right? I mean, what are fields doing with stigmatized information in the age of electronic medical records? And I'm not sure. I don't know what's going on out there. I think people don't know what to do. I think sometimes people also write things in code, often, right, where the physician will know what it is, but it's not using the words, you know, discuss disease in family or whatever, right? But I think particularly as we go to more electronic medical records, these are very difficult areas. And it was disturbing to me that people would say, you know, I called the hospital privacy officer, and they were very nice, but they could do nothing. They never got back to me. They said they couldn't do it. They said, you know, the system is not set up to deal with this. And I think we need to figure out, should we change it? If so, how? I think everyone needs to be in the room to figure it out.
Well, with that, last question.
Yes. How do I feel about pedigrees being scanned to electronic medical records? Well, there's a few issues there. That's a whole other topic, right? Because it's other people's stigmatized medical information that you're then giving. I think ideally, if medical records are completely confidential, right? We already have family histories, and I think from family history to pedigree is not that big a step, and presumably, I think pedigrees in research, you know, de-identified research records gets more complicated because they can be so identifying. But I'd have to think about it more, but my immediate thought is that it probably happens, and we hope that medical records are completely confidential, but of course, as one thing psychiatrists often say, is nothing's completely confidential. So.
With that, thank you very much.
You're welcome.